Kia ora koutou and welcome to tonight's Goodfellow webinar. Te Whatu Ora presents Te Tiri Whakāro, Sharing Knowledge. My name is Pulasti and I'll be the facilitator for tonight's session. This webinar is about improving patient outcomes in long-term conditions. And the topics will include self-management support principles with Dr. Janine Bycroft and Francis King providing an overview on the journey to well-being Huarahi Ora Guiding Principles. These principles have been developed to support providers delivering self-management programs for patients with long-term health conditions. We then have Dr. Alan Davis presenting an update on atrial fibrillation with the goal of improving patient outcomes. Finally, we have clinical updates by Dr. Tutty. So tonight's speakers include Dr. Janine Bycroft, who is a specialist GP, founder and CEO of the award-winning Health Navigator Charitable Trust, Home to Healthify, New Zealand's leading health information website. With a master's degree in public health, Janine has been at the forefront of self-management support, care planning and digital health for over 30 years. Francis King is a healthcare professional with over 30 years' experience. Her commitment and background in mental health nursing, combined with extensive leadership and management roles, including primary care, kaupapa Māori services, community innovations and research, has been beneficial in the development of Huarahi Ora. Dr. Alan Davis is a physician and geriatrician based in Northland. He is the Clinical Director of Older People's Health for Te Whatu Ora Northland and also Clinical Lead for the Northern Region Health of Older People Network. He has an interest in medication management and stroke care and is currently acting chair of the National Medication Safety Expert Advisory Group. And finally, Dr. Tutty is a GP based in Auckland and primary care advisor for Te Whatu Ora Counties Manukau. So without further ado, I'll pass on to Janine and Francis for our first talk.
Kia ora koutou. Great to be here and to have the opportunity to talk about the self-management support and Huarahi Ora program. So first of all, what is self-management support? So look, there's lots of definitions, but really it's about what is the help and support that we can provide to whānau with long-term health conditions to enable them to manage more effectively at home and to optimise their health and their well-being. So this is everything from supporting them with growing their knowledge, their confidence and their skills to manage their health optimally and to know when to seek help. What are the minor things they can manage at home? How can they be proactive about their health? Or how can they be really partner in their care plan? Are there programs that they can attend that can support them on that journey to optimising their skills? So this is the common things we know about, such as diabetes self-management programs. It's also everything such as pulmonary rehab and cardiac rehab programs, but it's also some of the digital solutions that are now available. And on the Healthify website, we do have a whole lot of apps and online programs that support people to develop those self-management skills, both for themselves and for their whānau. So it's a wide range of things, but with this program, we did end up focusing quite a lot on the programs that often are delivered in the community. So why does this matter? Well, look, this slide I find is really interesting and is looking at some of those determinants of health. And look, there's lots of different diagrams and ways that this can be interpreted. But I find this one really interesting just to look at the fact that we spend so much time and effort focused on medical care, but there are all these other, we know that socioeconomic factors are obviously hugely important, but these individual behaviours are 40% of that impact. And we don't really put as much time and effort supporting whānau with that area as might be ideal. So how can we support whānau to really know how to take their medications, to keep taking them? We know that adherence at 12 months for long-term conditions, medicines is only often at about 50%. So how do we optimise that and support people to be on the right medication and treatments? What are those choices we make throughout the day that can improve people's health outcomes? And we know there's a lot of room in that space for things to improve. So the background is that there's been some self-management support and care planning principles were developed back in 2016 by the Ministry of Health, and we were commissioned to review those and provide an update and look at long-term conditions self-management support programs across the country. We did this in collaboration with Health Literacy New Zealand, so Susan Reid and Carla White, and did a real co-design approach to look at what were the key principles or attributes that were needed for these programs to be optimal. So I'm going to hand over to Fran, who's now going to go through the next few slides. Thanks, Fran.
Kia ora, everyone. So a summary of the activities that we did was we started with a literature review, which included both international and national literature. As Janine mentioned, we reviewed the 2016 publication of self-management support and did an environmental scan. We, through community engagement, so we moved from the top of the North Island all the way down to the bottom of the South Island and talked to many providers, including national providers, regional providers, local providers, secondary providers, primary care, community, voluntary groups, men's groups, Māori providers, Pacifica providers, and people with lived experience, including disability. From that, we got a pretty good indication of what was happening across the country. We formed a kaitiaki rōpū that was made up of representatives from clinical services, self-management support, Māori, Pacifica, disability, lived experience, and used a co-design used provider focus groups to co-design these new guiding principles. The key findings from that work included that there was quite a clinical focus on individuals. A lot of the self-management support programs that were delivered were education style delivery. There were workforce challenges, challenges around funding of self-management support initiatives, often being funded as pilots or maybe for 1 year, which made it really difficult for providers to plan out long term. There was real variability in access and how people got to know about what programs were available, when they were running, where they were running, that sort of thing. And there was a real mixed understanding of what co-design is. So from this work, the changes that needed to shift to make effective change in the long-term condition space included having a more collective and whānau-based approach, using behaviour change theory and adult learning focus, as opposed to telling people what to do. Having facilitators with lived experience was seen as really beneficial to groups, having sustainable commissioning, having accessible delivery, and also authentic co-design. So as we went around the country, we talked about the term self-management support and got a lot of feedback how it didn't sit well with a lot of people, particularly Māori and Pacifica, who have a more collective whānau-based worldview, and also people with disabilities. So we asked questions around alternate terminology, alternate terms, what would sit better with them, and the new term, journey to wellbeing, Huarahi Ora, is what's been selected.
Kia ora, ko Jo Henson taku ingoa. He pau kai whakahaere matua, GM Māori, and Community Health for Whatu Ora Campus Health. I was a member of the focus group that had input into driving the direction of the resource Huarahi Ora. Huarahi Ora Journey to Wellbeing is an exciting, new and culturally relevant resource developed with the community that provides practical application to support providers and whānau in their journey to wellbeing. We are excited to be using it and hope you are too.
So, Journey to Wellbeing, Huarahi Ora, has an image of waka, which was something that people felt. They often refer to their journey of having a long-term condition and having to navigate that. In the hull of the waka, we have two foundational principles, whānau-centred and co-designed. And in the waka hoi, we have culturally safe, meaningful, accessible, skillfully facilitated and sustainable. So the foundational principles, whānau-centred, what does that mean? Whānau voices are central to what is done with them. They're involved in the decisions, the practices, the actions, and they are experts in their own well-being. Co-designed is partnering with community. So we heard lots about how when community and people's natural supports are involved in their programs, in their journey, how beneficial that is. This prioritises relationships and helps to build capacity and capability within community. The other 5 guiding principles, as mentioned, culturally safe, is having respect for cultural practices, having culturally safe content and programs, and having a diverse and inclusive workforce. Meaningful, being holistic and innovative, being responsive to what whānau and community need, being outcomes focused, and whānau and community are part of determining what those outcomes are, and there is support for behaviour change. Accessible, having programs that are welcoming, safe and reliable, integrated, and community is supported to participate. Skillfully facilitated, workforce development, having good workforce development and support, having lived experience and peer support and mentoring. And then sustainable, that there is continuity of programs, that it's resourced adequately, that there's really good leadership, that it's connected within community and evaluated. So what's in the resource for you guys? Each of the principles is set out quite basically, so there is a very short definition of what the principle is. Something we heard is that people around the country, they didn't want lengthy guiding principles. They wanted things that were easy to read, easy to understand, and practical. So we've heard that. There is a list of reflective questions that providers can use within their teams. There's some assessment tools with 2 levels being essential and leadership, and there are links to useful resources.
Kia ora koutou, ko Sarah Paka-Ahau, ko te kaiwhakahaere matua o te haura o Kahununu Executive. I was part of the focus group that had input into guiding the development of the resource Huarahi Ora, a Journey to Wellbeing. For me, it was important that facilitators have a resource that was simple and meaningful to both providers and whānau. as whānau already know what's important to their well-being. I believe this resource supports that whakaaro nicely. I'm really excited that the resource is completed. A big mihi to Francis and Sarah for their work around this, and look forward to seeing it being utilised in the community. Ngā mihi.
So a big thank you to everyone that has supported in putting these guiding principles together for our sector. So there's a bit of a list there, and you guys can jot these website links down, journeytowellbeing.nz or Huarahi Ora.nz. They both go to the same website. Cool. Do we have any questions? Do we have time for questions?
It's interesting to see kind of, I guess, some of the changes that you're implementing. Can you talk to us more about some of the challenges that you found sort of on the ground in terms of actually actioning change?
I guess some of those were covered in one of the slides. The principles, in essence, seem quite simple and straightforward, but they are more challenging for providers to put into place. Yeah. Some of that is kind of traditional, I guess, what you would call more traditional and mainstream ways of working. Yeah, so this is quite a shift for some providers.
How does Huarahi Ora differ from or incorporate Te Whare Tapa Whā and or the Meihana model?
So it is, you would have seen in some of that, so one of the things is it's very whānau-centred. So if looking at the other principles that include other services, community supports, those sorts of things, that's a big shift. So if people are needing, social services, mental health services, all that's factored in.
I can't see any other questions have come through just at this moment, so I will hand over now to Ellen to take over and talk around atrial fibrillation. Ellen.
Kia ora koutou katoa. My name is Alan Davis. I'm a geriatrician and stroke physician from Te Tai Whakāro, Northland, and currently the co-lead for the National Stroke Network, which is more why I'm here. I also had the opportunity just over 2 years ago to present at a Goodfellow session the launch of what at that time was an updated atrial fibrillation health pathway. Based on the 2020 European Society for Cardiology atrial fibrillation guidelines. So it's kind of timely that I have been given the opportunity to provide some update on that, and we'll talk a little bit about what's changed since that 2020 guideline, or what's come up in the last 4 years. Also, my other disclosure is that I'm not a cardiologist. So I'm just thinking ahead to the Q&A session. I'm very much a generalist when it comes to cardiology, so just bear that in mind that this is coming from someone who doesn't know a lot of cardiology, but stroke is really the angle that I'm here for. I'd just like to quickly show this slide. You can't get a stroke physician without showing a slide on stroke. This is the latest data that's come through from the ARCOS 5 study, and I'm sure many of you, and I think most of you, are aware of the ARCOS studies. ARCOS 1, 2, 3, 4, and 5 across the x-axis. The ARCOS studies spent a year each decade finding every stroke that happened in the Greater Auckland area, and then followed those people who had experienced those strokes for a further year after that. And these are just the basic sex and ethnicity rates over those 5 4 decades. So 1980 was the first ARCOS study, and the last one 2020-21. So we've got over 40 years of tracking how things have been going in terms of stroke, and you can see that over the first 4 ARCOS studies, so on the left is a graph male versus female, and on the right breakdown by ethnicity. Over the first 4 ARCOS studies, things seem to be improving decade by decade in terms of stroke incidence, and the last one, unfortunately, showed a significant change. And when you look at it by ethnicity, the change was pretty much entirely in non-European people. I think that data point for Asian people in 1980, the population of Asian people in Auckland is probably very different to what it is today, and very much smaller. So that data probably needs to be taken with a grain of salt. However, you can see that for Māori, Pacific, and Asian, the stroke incidence is now rising. And that's not just a one-off thing. That's we're seeing this sort of thing in disadvantaged populations around the world, or vulnerable populations. That stroke rates are now increasing, and you'll be seeing that coming through probably a bit in your practices. The important thing in terms of atrial fibrillation is Māori and Pacific people experience the onset of atrial fibrillation a decade earlier than non-Māori, non-Pacific. They experience strokes 15 years earlier than the European counterparts. Those strokes are more likely to be attributable to atrial fibrillation. Atrial fibrillation strokes are worse than non-atrial fibrillation strokes, and the outcomes are worse. So people who experience a stroke, if they're Māori and Pacific, if they're in atrial fibrillation, are less likely to survive and less likely to have a good recovery. So I think it's unfortunately the curve we would hope would be continuing to fall is not. So this is the health pathway that we presented here just over 2 years ago, and I hope it's familiar to a number of you. And what I'll talk about is some of the things which might represent changes that are coming up. So the health pathway, as I said, at that point was based on the European Society of Cardiology structure. They had called it the CC to ABC, so confirm AF, characterize, and then treat using the ABC abbreviation there, avoiding strokes, better symptom control, and comorbidity management. And the first part of that was around confirming the atrial fibrillation. The recommendations are very clear now that you need to do the electrical measurement of heart rhythm in order to diagnose atrial fibrillation. But you can use any of these sorts of devices. You can't use a non-electrical device to diagnose AF, it should be confirmed. But in terms of what you do in your surgery, if you identify somebody who has a rhythm which may be atrial fibrillation, you can use any of these sorts of devices. And I'm sure a number of you will be using that Cardi device up on the upper left, $200 a shot. Obviously 12 lead ECGs. If you're ripped, you can get a nice little stick-on patch on your chest. Otherwise, you're stuck with things which have lots of leads. And if you've got the money, you can use an Apple Watch. Those are all validated ways of diagnosing atrial fibrillation. We still talk about this about single lead rhythm strips should be at least 30 seconds, or a 12 lead should be at least a full A4 page of atrial fibrillation to qualify. But there's no real data that supports those sorts of criteria. And while that's recognized, we still would probably use those criteria. This is the revision, which was published in September, so just a couple of months ago, from the European Society of Cardiology. Have moved things in quite a different way, although still a lot of the subsets are the same. So now bringing comorbidity and risk factor management up to the front. Much more consumer-centered and shared decision-making. Avoiding stroke and thromboembolism, reducing symptoms by rate and rhythm control, and ongoing evaluation. So that's now the structure of the Society of Cardiology pathway. The evaluation is still the same as it was before, but just to reinforce that that to evaluate atrial fibrillation still requires a 12-lead ECG looking for the underlying cardiac disease, which may be either causative or associative. and a transthoracic echocardiogram, which is important for determining how myocardium is affected. Most pathways around the country should have primary care access to transthoracic echocardiography for the initial workup of atrial fibrillation. Everyone in atrial fibrillation should have at least one echocardiogram in their life, but often only would need one. And this is the way that the new information has been laid out in that pathway. So that's the CARE, as you saw before. Green recommendations are the highest grade of recommendation, class 1 recommendations. Yellow, still pretty highly supported recommendations, class 2A. The orange ones are a bit less well supported in terms of the evidence base, and the red ones are things that you don't do. So this is quite a nice, I think, way of laying out where we're going with changes. So these are just the things. I've pulled out a few of these because we're not going to talk about all of them. I'd need an hour to do that. So let's just talk about the ones which I think are interesting to us. So blood pressure treatment, you're probably aware of the new guidelines, which now are suggesting, is in terms of secondary prevention, at least anyway, and that blood pressure should be lowered to the 120 to 130 systolic range. So there we are. 5 millimeter blood pressure reduction in atrial fibrillation leads to a 9% risk reduction for cardiovascular disease. Secondly, the SGLT2 inhibitors are now class 1 recommendations for heart failure associated with atrial fibrillation. And that's heart failure with preserved or reduced ejection fraction. So heart failure with atrial fibrillation with preserved ejection fraction, there are better outcomes if you use SGLT2 inhibitors. And I'm sure everyone's thinking, well, they're not funded, which is true. But hopefully they will be before too much longer, and there may be some of your patients, consumers who would be willing to pay for that. But that is a class 1 recommendation in the latest guidelines. And then moving on to avoiding stroke. There's a change in recommendation around the use of risk scores, so using a locally validated risk score, which we don't have in this country. The CHADS-VASc, they have simplified. You can continue to use the CHADS-VASc because you're currently using it, but they have simplified it to a CHADS-VAR, which is taking out the gender or sex score. Females score 1 in the CHADS-VASc, but all that does is we change the threshold for treatment by 1. So they thought it made sense just to take away the score of 1, and then we just leave the threshold for treatments the same for everybody. So that's something that we will probably put into the next pathway. Reinforcing antiplatelet therapy is not an alternative to anticoagulants for atrial fibrillation. Antiplatelet therapy does not work, does not prevent thromboembolism in atrial fibrillation, and does increase hemorrhagic consequences. A change here, the use of the DOAC using a DOAC is now the first line recommended treatment, except for mechanical heart valves or moderate to severe mitral stenosis. So mild mitral stenosis is fine. This is moderate to severe. Hypertrophic cardiomyopathy now no longer is an exception to the use of DOACs. So that's a modest change in that area. This is a small change as well. So you can continue to use risk scores for hemorrhage, but the reason for doing a risk score in hemorrhage is to identify areas that you can modify risk factors. Modifying those risk factors, class 1. Class 3, do not use risk scores to balance the risk score for thromboembolism. This is not a way of subtracting one from the other and deciding whether you should anticoagulate them or not. And then finally on this one, don't combine antiplatelets and OACs. And I see that amongst my colleagues, not that infrequently, adding an antiplatelet to an oral anticoagulant for people who've had a stroke while on anticoagulants. It doesn't work. So all it does is increase risk. And even with unstable coronary artery disease, antiplatelet therapy in addition to oral anticoagulants should stop once the disease has been stable for 12 months. And then moving on to the reducing symptoms and rate control, a couple of things to look at. I think we're going to see some changes here over the next few years, but not quite through yet. One thing which was a little, probably will take some of us a little bit by surprise, digoxin's now back has kind of come full circle and is back as being a recommended class 1 recommendation for rate control, particularly in people with impaired left ventricular function. Previously, it was a third choice rate control agent. Now you can use it more upfront. So people with hair my colour will remember that used to be the case. And then with rhythm control, so particularly for paroxysmal atrial fibrillation, symptomatic atrial fibrillation, rhythm control is probably getting a little bit more support than it had before. But I think our goal is still primarily around rate control. So just one of the things that we do see, as I say, atrial fibrillation and quote unquote breakthrough stroke. There's been some good data on that in recent times. Causes, 25% due to non-atrial fibrillation causes, so competing factors such as large vessel arterial disease. 33% recognised issues with adherence to medication, and then 40% due to true breakthrough, although some of those may well be adherence as well. So the do's and the don'ts: do change from warfarin to a DOAC unless you've got a mechanical heart valve, mitral stenosis, or advanced renal disease, which doesn't allow you to use DOACs. Do optimize OAC treatment adherence, and do put in managements for other factors such as hypertension and atherosclerotic disease. But do not add antiplatelets. Antiplatelets are related to worse outcomes if you add them to OACs, as I said before. Don't change between DOACs. There's no evidence that changing from one DOAC to another makes any difference to outcomes. And don't change to warfarin if people are already on a DOAC. So often it's around making sure that you've done everything you can to optimizing the oral therapy without blinking and thinking we're doing a good thing by changing the medication the person's taking. And then finally, just a brief mention about what's coming. I'm hoping that before too long we will have some localized assessment tools for for stroke risk. Talking to our colleagues who do the cardiovascular risk management studies, they've got the raw data to do an equivalent CHAS-VASc with ethnicity breakdown, because at the moment we don't have a way of assessing that. Prolonged monitoring for atrial fibrillation after what appears to be an embolic stroke is something we don't routinely offer, but probably should. It's a resource issue, so most of us can't get really access to prolonged Holter monitoring. We're lucky if we can get 24 to 48 hours, and it's probably not enough to be sure that we're not missing an atrial fibrillation as a cause for paroxysmal atrial fibrillation as a cause for embolic stroke. I think we will see a change in the balance between rate and rhythm management with over the years some emerging evidence that rhythm management is a little more important than we have been thinking in the past. Left atrial appendage closure is now being increasingly used outside of this country as a way of getting around problems with anticoagulants particularly. You still need to be able to take antiplatelets though. I'm not aware that certainly anyone in the northern region is doing LAA closure, and certainly not in the public sector. Atrial fibrillation screening is something I get in trouble with my public health colleagues from time to time, but I think the evidence is starting to build that or at least the pressure is starting to build that we need to be far more active in screening, either opportunistic screening or age-based screening, or in our case, perhaps ethnicity-based screening for atrial fibrillation. And then finally, and it won't be happening before Christmas. It's obviously time to update our community health pathway.
Right, thank you very much, Alan, for that presentation. So we have a few questions that have started trickling in. So you sort of mentioned at the early part of your presentation about how ideally we do want an echo done at some point in time for our patients. I think one of our attendees, probably from a rural setting, kind of talking about the challenges of actually getting an echo. And is there anything you can say to that? What are the issues around having a massively delayed echo, or having a echo request declined in someone where we're querying AF, or where we've confirmed AF on ECG? Anything you want to mention that, or how we in primary care can manage that dilemma?
I acknowledge that our resources for supporting echo services are pretty thin in places. So even though we've got echo services carrying vacancies, the ability to fill those vacancies is difficult. I acknowledge that. I think, however, that there is a general acceptance amongst echo service and cardiologists that this is clearly an indication for a transthoracic echocardiogram. So once you have confirmed atrial fibrillation using either single lead or a multi-lead ECG, it's appropriate, and it doesn't matter what type of atrial fibrillation, whether it's paroxysmal, new onset, persistent, or atrial flutter, which also is essentially a variation of atrial fibrillation. All of those should be treated the same. So I think you get the request in, it should not be declined. Sure, it may take a long time, but if there's services trying to decline it, then we probably have some work to do nationally to actually change that, because I don't think it's acceptable not to do that. And I think the work we've done in the northern region, very clear acceptance from all cardiology services that this is a clear indication for doing the echocardiogram.
Another question, how many potentially preventable strokes do you reckon there are in the northern region from underdiagnosed and undertreated AF? What kind of burden of missed DVAs
we don't have the data yet from ARCOS 5, and we've got to remember, between ARCOS 4 and ARCOS 5 we had the introduction of DOACs. So we may see a change in that, but the information we had from ARCOS 4, which is of course going back to 2012, 2013, is that 30% of all ischemic strokes were atrial fibrillation related. And we have about 2,500 strokes a year, acute strokes a year in the northern region. So 30% of those are atrial fibrillation related. Of that 30, 8 were on anticoagulants. So 3/4 of people were not on anticoagulants. The majority of that 3/4 were known AF.
Mm-hmm.
So it wasn't, for most of them, it wasn't, this is the first time AF has been appreciated. I'm hoping we'll see a little bit of a change in that when we get the data out of the latest ARCOS study. So, but I, in my own practice, I see a lot of atrial fibrillation related stroke, which is potentially preventable, and they are nasty strokes. These are the commonest strokes that, these are the commonest strokes we're sending for clot retrieval. Because they're big clots that come out of the left atrium. They plug big arteries in the brain, and if we're lucky, we get there in time to pull that clot out, and that makes a difference. And I'm just looking at some of the data today on change over time, and we've seen since the advent of clot retrieval what appears to be a significant increase in the likelihood of getting out of hospital earlier.
Next question, how important is losing weight for AF management? And maybe I would add on, if you have any other thoughts on lifestyle management as well.
Obesity management was in there as a significant cause and exacerbating factor, I should say, for atrial fibrillation, and that losing weight does reduce the risks of atrial fibrillation and the likelihood of atrial fibrillation. So that's important. So yes, so weight absolutely is in there. I think it was a class 2 recommendation though from memory. I need to go back and look at that slide. The other one, of course, which might be concerning to some of us, is alcohol at more than 3 units per week is a causative factor for atrial fibrillation. So there's quite a few things about what you stick in your mouth that might make a difference.
So just to clarify, you said 3 units per week of alcohol?
Per week.
per week. That's not a lot of alcohol.
Yeah.
Good to know. You mentioned about the importance of maintaining compliance with oral anticoagulants. Can you talk a little bit about the main reasons why patients may not be adhering to their medications? I guess in terms of us as clinicians actually, encouraging adherence and maintenance. Yeah,
we all struggle with that. And quite honestly, I'd like to reflect that back to that question back to Janine and Francis, because they've probably got much better answers than I have around that. Making sure that people get the medications readily, that a lot of it's around understanding why they're on it. So how much time we can actually spend with them doing that, the shared decision making. So people actually are understanding why they are making the decisions to take that. I think there's good evidence around that. There is very little evidence around changing from a twice day to a once day presentation in order to achieve better adherence. So the studies that I've seen on that don't show any real difference. But I think it's very much around the shared decision making is where the thrust is coming through now. Warfarin clearly is difficult for people. It's a troublesome drug, and I'm personally very pleased to see it disappearing. In some ways, that makes it more dangerous because we get less used to using it. But I routinely move people off warfarin unless there's a good reason not to, such as valvular heart disease, mitral stenosis, or severe renal impairment. But even with that now, with the newer 10-ACE inhibitors coming along, we'll be able to treat people on dialysis with orals.
Right. So
non-PKAs.
Right.
We don't have them in this country, but they're well available overseas. But they're standard discussion. In fact, I think the worst of the 10-A's is rivaroxaban, but that's the one we've got. I personally use dabigatran as my preferred choice because I can reverse it if somebody comes in with a stroke, and I can still thrombolyze them. But I think internationally that would be a drug that's very little used.
So I think it was interesting. You kind of mentioned in your don'ts list, you wouldn't transition someone out from a DOAC to warfarin, even if, I guess, with what we've got at the moment, let's say you've got your aging person who started off with normal renal function, and it is deteriorating quite rapidly. You'd still keep them on.
Yeah, well, rivaroxaban's now licensed down to 15 mils per minute EGFR. There's evidence that actually it's still safe even below that, but it's licensed to 15. So if you're getting below that, it's not going to be a primary care decision. You'll have a renal specialist involved, I would expect.
Are you aware of any research at the moment investigating hypercoagulable states in relation to stroke incidence?
Nothing in particular. I mean, clearly, the hypercoagulable states are related to stroke, but we see them more around venous thromboembolism than arterial thromboembolism. But they're actually a pretty rare cause of stroke in general stroke experience. But we always look for it. We would see a steady trickle of people with malignancy-associated hypercoagulability causing stroke. So I would see probably a handful a year. In that situation. So it's something we'd always keep an eye out for, and particularly in younger people. But I gotta say, we don't do that much testing for it these days because it really isn't very common, not in terms of the testable sorts of hypercoagulabilities, particularly in people who otherwise fit well.
I'm not sure how relevant this is necessarily to AF specifically, but maybe more putting your older people's health hat on. At what stage do we stop a pacemaker battery replacement for someone in their 80s, frail, and having complex comorbidities such as dementia?
Okay, yeah, that is very much a geriatric medicine discussion. All right, I'll give it a go. Time until death is what we've got to work with. So how much time do we think this person has got? So age in itself, age per se, time from birth has little relevance, doesn't it? So a fit and well 85-year-old will have a life expectancy of 8 to 10 years. So it's not going to trouble you to put a new battery in that person's pacemaker. And then you've just got the person that the question relates to. which really requires a conversation with the individual, and in this case, if they've got advanced dementia, their family, around what we're seeking to achieve. So that's a shared decision conversation. I certainly, if it's somebody who is as described there, I'd be talking about the value of persisting with that. Most pacemakers in that setting are around things like managing bradycardias and bradyarrhythmias, and the person probably doesn't have too much need to have their heart rate increased if they're pretty sedentary. So it would be a relatively easy discussion, I think, to suggest that it's probably not doing them any good. It may well be time not to be pursuing that and actually be focusing on other quality of life issues.
And final question that's come through on Q&A, how often would someone with stable AF on anticoagulants need follow-up with cardiologists?
Stable AF, asymptomatic on the anticoagulants, I'm presuming they've had an echocardiogram, which doesn't show any significant disease. I wouldn't think they need to go anywhere near a cardiologist. So it becomes, I think we agreed when we wrote the pathway last time that if we're thinking about rhythm control versus rate control, it's probably time to start talking to a cardiologist. And if there's significant structural disease of the heart, then time to talk to a cardiologist. But up until that point, it's entirely appropriate to manage in primary care.
But one more question in before I hand over to Sue. So just one more's come through. Pre-employment medicals and, someone who's been diagnosed with atrial fibrillation, young and otherwise fit, refusing to go on anticoagulants. What are your thoughts around their potential stroke risk and also any liability? They've said to the provider, I guess, employer versus employee versus healthcare professional, I guess, from an employment point of view.
Well, I'd want to know what their heart's like. If the echocardiogram show left ventricular function is normal, left atrial size is normal, then you would probably be talking about getting back into sinus rhythm. If they're 40 or 50, they are at low risk of cardioembolic stroke if they otherwise have no other comorbidities. So you can talk to them about their low risk and about whether they would want to go on anticoagulants. They're going to score 0 on a scale, on any of our scales, with that picture. So it would be appropriate not to be anticoagulating them, probably. In terms of our responsibility to the employer, we've identified that they're at very low risk. I don't think that our responsibility goes beyond that.
I'll hand over now to Sue for clinical updates.
Thank you. So there's a number of things to cover tonight, but I thought that since a national pertussis epidemic was declared last Friday, we should perhaps start with that. And the messages are pretty straightforward, and you're probably well aware of them, but to remain vigilant of this. The big one is to immunise our hapa mamas, and that vaccination is from 16 weeks in pregnancy and in every pregnancy, to prioritise the immunisations for baby and get them protected as soon as we can. To consider whether the extended whānau around pregnant women and young babies should also be vaccinated, although this is not a funded vaccination. And then to encourage your own clinic staff to think about vaccination as well. And the testing for this is the flocked swab, which I think we all know very well, and it's a nasopharyngeal sample, and within 2 weeks of the onset of symptoms. Now, there may be a place for testing for people, but also if it's very obvious that this is what the condition is, there may be a place for not necessarily testing unless you've been directed to by public health. The other condition that's around New Zealand, and we've had a recent case in Waiheke Island in the Auckland region, is measles. There is now a national pathway on measles, on health pathways, so that everybody should be aligned in the way this is being managed. The big difference from pertussis, I guess, is that you need to notify public health and you need to isolate the patient even on suspicion. So we're taking measles very seriously. Again, the call for vaccinations, and this is particularly our Maori and Pacific and quintile 5 patients. And just a thought that babies travelling overseas should be aware that there is measles around the world as well. And again, the test is the one we know well, the flocked viral swab. But for measles, you can do a throat specimen or a nasopharyngeal, although the nasopharyngeal one is preferred. And this is from day 0 to day 7 of the rash starting. I wanted to talk a bit tonight about the funding and subsidies health pathways, which are coming very shortly onto our health pathways. So there's been a lot of work done on this, and it's a real wealth of information that's there. It's in 3 sections: primary care funding, national program funding, and patient accessible funding. And it can be short-term, long-term, or one-off. There's all sorts of subsidies available. So just with a quick run through what's there. Long-term funding, all these possibilities are there from primary care funding. So I looked at one under PHOs, and it was talking about capitation. So if you've ever wondered about capitation, you can find this on there, and there's all sorts of links that will give you even more information on capitation. National program funding is another section, is the second section, and Health New Zealand looked under subsidies and payments there. And I don't know how many people, when someone comes in and asks for a breast prosthesis subsidy or a wig subsidy, which I both had people ask for this, and you sort of flounder a little bit as to where you're going to find this, but it will all be there on these pages. ACC, there is a whole suite of pages on ACC that are being developed, and some of these go right back to the beginning of how you become an ACC provider, with information on there. But just looking at the degree of ongoing support that's available for people under ACC is quite wide-ranging, and there's information on all of those. Another one on the national pathways that I thought I'd mention is the Best Start Kauai suite of tools that are available and should be there in your PMS systems, because they are certainly compatible with all the PMS systems around primary care. And these are the tools for Best Start Pregnancy, Best Start Pepi, and Best Start Mama for the 6-week check, as well as the first antenatal visit. And there is funding available to practices who complete these forms, plus a koha that is given for the patient as well. And then looking at patient accessible funding and payments. And I scrolled down these and had a look through them and picked on the driving and transport one, fitness to drive. And we know how difficult that conversation is with our patients when we're unable to continue to sign the medical form for fitness to drive. And just having access to some of these other possibilities of how people can get around, and the half-price taxis has also been something that some of my patients have asked me about, which you'll find here. And just another shout out to another new pathway, a national pathway that's been developed with a lot of information that's useful. And I pulled this one section off it about to assess the type of psoriasis pattern that's present. And under each of these types, there's the investigations and management for them. So another pathway you might like to have a look at. Now, moving on to the pharmac section. Alan mentioned the use of empagliflozin in heart failure, and from the 1st of December, we will have access to this medication only for patients with reduced ejection fraction at this stage, but there's still conversations going on with Pharmac that it might be for people with normal ejection fractions as well. But at the moment, it's just for reduced ejection fractions. So most people will be aware of empagliflozin for the treatment of diabetes. There's also conversations going on about access to empagliflozin for people with renal disease. So the benefits in heart failure are as it reduces the risk of a cardiovascular death, fewer people will need to go to hospital, and an improved quality of life for people. And it's now bringing New Zealand in line with international best practice. And just a couple of comments at the bottom there about heart failure, that Maori and Pacific people are 4 to 5 times more likely to be hospitalised with heart failure and have double the chance of dying from chronic heart failure than other people. And if you do have a patient with an ejection fraction less than 40%, 1 in 3 of them will be dead in 3 years. So we've now got access to this medication. So, and this is the special authority criteria for it. So the patient has heart failure, the patient has a functional class of 2, 3, and 4, or 4. They have a documented left ventricular ejection fraction of less than 40%, or if an echo is not reasonably practical, and we've talked about the difficulties getting access to echoes, particularly in an appropriate time frame, then you can go ahead and prescribe this treatment if you think your patient would benefit from it. However, it's only for people who have already been optimised on standard congestive heart failure treatments. So just a bit more explanation on that. So your functional classes 2, 3, and 4 is anyone with any limitation on their physical activity. Even if they're comfortable at rest, if they find that they become tired, short of breath, get chest pain or palpitations on any exertion, then they would qualify. And our standard heart failure treatments are ACE, ARB, and ANI or Entresto, being on a beta blocker and being on spironolactone. And a few notes about empagliflozin for heart failure. The maximum dose that has been researched is 10 milligrams, so there's no room for increasing up to the 25. Interestingly, they've also changed the special authority now for empagliflozin, that if you are on a funded GLP-1 agonist for treatment for your diabetes, you can now get a funded empagliflozin as well for the treatment of your heart failure. It's not for use in people with type 1 diabetes because of the risk of ketoacidosis. And just a reminder that I'm sure you're well aware when prescribing empagliflozin to make sure you go through the risks of prescribing. The risk of ketoacidosis, as I've mentioned, and avoiding keto diets, which can be an issue for people who have weight problems. And I talk to my patients about how empagliflozin helps the sugar to go through your body and out in your wheeze or your mimi, and that because it's drawing the sugar off, it takes the water with it. Because you're peeing out more sugar, then you're at risk of genital infections. So it all makes sense to people, and you can explain the side effects, I think, in terms of the action of empagliflozin, and therefore it doesn't feel like something that you're causing. It's just the natural consequence of taking the drug, and just to warn them to stop it if they do get at risk of dehydration for any reason, such as having surgery or getting a gastro bug, and to be careful to look after the genital area. And if they do get severe pain in that area, such as we would know, as Fournier's gangrene, which is a rare complication of empagliflozin, that they come and see us. And Jerry Devlin did a webinar a few months ago on heart failure, and one of the pleas that I pinched his slide to talk here about up-titrating medication. And that was his plea, was to make sure that we just keep pushing the medication up, because the bigger doses are more helpful in preventing the consequences of heart failure. So be prepared to stop the loop diuretics if people don't need to be diuresed, if their BNP is normal and they have no congestion symptoms, and that allows us a little bit more play with the blood pressure to be able to push the other medications up that we know will have bigger differences in outcomes for people. With the ACEs and ARBs and spironolactone, we need to watch the potassium as well, and with the beta blockers, just to watch the heart rates. But otherwise, up titration of medications is so important. And another change in special authority that's happening from the 1st of December is for the stimulant treatment. So our treatments for ADHD and narcolepsy. So that's your methylphenidate, dexamphetamine, and modafinil. I've talked a number of times already in these sessions about the changes to the ADHD medication, but it has come to effect will come into effect on the 1st of December, that you no longer need approval to renew the medications, even though you do need a pediatrician or a psychiatrist to initiate at this stage. And anyone with a current or recent special authority, so that's within the last 2 years, will automatically be transitioned over by Pharmac without us having to do anything, so that their special authority will continue. This means that we may be responsible for managing the ongoing treatment and whether it's still appropriate for the individual and if they're benefiting from it. But if there are any concerns, then it's still possible to go back and seek specialist input. And the other change that's happening from the 1st of December is that nurse practitioners can now prescribe these medications in the same way that other primary care people can, GPs can. And a further change relating to ADHD is that lisodexamphetamine is now available. And again, I've talked about this medication previously, that it is a prodrug and therefore has a much more gradual release through the day and less potential for abuse. And this is now available as well because of the problems with the availability of medications for ADHD at the moment, with a worldwide shortage. And this comes in 30, 50 and 70 milligram tablets. However, it's not considered a first-line medication. It's only for people who haven't had enough sufficient benefit from the other formulations, have intolerable side effects, have problems with adherence, or if there is significant concern regarding abuse and risk of diversion of their medication. As I mentioned, it's a once daily treatment, but for each dose, there is only 30 tablets allowed per month. So if you can't take 2 of one tablet, you need to move up in the dose strengths. And it's hopefully going to help with some of the supply issues impacting with the other stimulant treatments. Looking forward, I didn't think that we could leave 2024 without some mention of AI, but please don't ask me any questions on this in the chat afterwards, because it's not my area of specialty. But I would like to thank GPNZ and Well South for the work that they've done on this. The advantages were documented on the survey that Well South did GPNZ did, sorry, I think, improving the efficiency of our consultations, reducing clinician burnout, reducing the administrative burden, and creating more time to focus on patient care. And that's been fed back by patients as well as by clinicians. But there are significant challenges and concerns over privacy and security and some of the outputs, because what we're talking about is generative artificial intelligence. So this isn't just recording what's being said, but it's creating and developing the content and using databases, data sets to enable it to bring up new text, images, and music. And so people will be aware of these examples that are already being used in primary care. And I can tell you that there is a New Zealand example that will be available in 2025. And I'm sure that we're going to hear a lot more about AI in the health area to come. So thank you very much. Any questions?
One question we've had through: how can we best achieve pro-equity prescribing of empagliflozin for heart failure if ethnicity criteria are absent from the special authority?
I think that it's on us all to be vigilant and think of these medications when we're seeing our patients with heart failure, and being very proactive with our prescribing.
A couple of questions just to clarify, just for our listeners, around swabbing for pertussis and measles. So you're saying pertussis, it's a nasopharyngeal swab only, whereas measles, it's okay to do either nasopharyngeal or throat if needed. Was that correct, Sue?
That's correct.
Right, yeah. Just with ADHD renewal, so great news that we don't have to keep applying for the 2 yearly, renewals. Will there be any implications for future changes in formulation of ADHD drugs as things come in and out of supply, as we've kind of dealt with over COVID, for example? Are you able to speak to that at all?
So there's still the fact that there's 2 different special authorities for the ADHD drugs, and so if they've got one particular special authority and you want to prescribe the other medication, you do need to apply for the special authority again, but you're able to do that if you've got the written approval for those drugs from the appropriate authority.
So I'd like to extend a big thank you to all our speakers once more for their contributions, and also to you as the viewers for your participation and involvement. So thank you very much, everyone, and hope you have a good, lovely night. Bye.